Good morning, everyone. This is Professor Denham, and this is Wednesday, and we're doing a review on Chapter 4. It's going to be a short review, so pay attention so that if you have any questions, you can always ask me through the email, or you can look them up in your book. I'm going to go ahead and share my screen and get started. Okay. So what we're looking at is Chapter 4. And let me go ahead and make this a little bit bigger for you. Okay, here we go, Chapter 4. This is how you probably starting to feel a little bit frazzled, but don't feel frazzled. Everything will be okay. Remember we talked about at the very beginning how people, a woman who is not expecting to have a baby, just says, oh, I'm not pregnant. So this is a little cartoon I found, which I thought maybe you enjoy. This is the triage area. So woman comes in, she says, nurse, I'm not pregnant. I'm just a big girl. And my belly pains is because I ate some bad food last night. Okay. We hear that. And the nurse says, just want to check. So come with me to the gynae room. Okay. And then a couple minutes later, what do we have? So the nurse says, I knew it, the power of denial. Okay. And this actually happened to me, as I already shared that with you. So we talked in Chapter 4 about prenatal care and also about adaptations to pregnancy, how the woman body changes during pregnancy and how she adapts to it. So the reason why we have prenatal care is to ensure a safe birth for mom and child. Okay. And we do that by promoting good health habits and also reducing the risk factors that are involved. So we teach them good health habits and we'll continue to stay with them, not only during the pregnancy, but stay with them after the pregnancy and for their life. And then you educate them in self-care for pregnancy and provide physical care, and then prepare the parents for the responsibilities of parenthood. Yeah, it's if you're not expecting a baby, if you're not, had been planning for a baby, the responsibilities of parenthood can be very overwhelming. It's overwhelming to everyone because now you're responsible for this little human being, and babies need a lot of care. So what we'd like to start out with is preconception care. That would be wonderful if they would come in before they got pregnant. Okay, so we can identify risk factors that may change before the conception. We can reduce the negative impact on outcome of pregnancy. We don't want a negative outcome. We want all positive. Everybody wants a healthy baby. So remember something, healthy moms equals healthy babies. And then we ensure a good nutritional state and, of course, immunizations. And we make sure that we check her rubella, make sure she's immune. And if she's not immune, NOT, not immune, then she'll get the immunization after she delivers, before she goes home. And she can breastfeed, even though she got this immunization. So rubella can be given after delivery. Again, she has to wait a whole month before she gets pregnant. Now you might say, well, she's gonna go home and get pregnant right away after just having a baby. Unfortunately, sometimes it does happen. So you have to be always on the alert, and you have to just give guidance. If you get a rubella vaccine, you do not get pregnant for at least 1 month. Okay. And then we want to make sure she's taking her intake of folic acid. This folic acid does help to prevent open neural tube defects in the developing fetus, such as spina bifida, or another one comes to mind is hydrocephalus. Okay. So if I was to ask you, a woman is coming in for her first prenatal visit. It is determined that she's 8 weeks pregnant. Okay. So which tests are typically performed at the first prenatal visit in a low-risk pregnancy? See, that was important information. So it's her first visit. And these are just typical tests that are performed, and she's low risk. So we test HIV on all our patients. Okay, complete blood count, absolutely. We'll skip over the next one, and it's rubella titer. Remember, I just said that. And then we'll do a vaginal culture. We're looking for gonorrhea and chlamydia. Because she's a low-risk pregnancy, we don't have to do a glucose tolerance test at this time. No, we'll wait till she's about 28 weeks before we do that one. Now, antepartum nursing care. Okay, so antepartum means, again, before birth. So again, number one is obtain the maternal history. Got to know all about your patient, medical and surgical. Then you want to know about her obstetrical history. And, we want to know if this is her first baby, second baby. And we want to know, too, if it's a term baby, premature baby that she had. So we want to know all about her, okay? So we can do it two ways. We can do the 2-digit, which is the gravid para, or the 5-digit, which is the GTPAL, which means gravid term, premature AB or abortion, miscarriage, and then living. And the next one, you assist with the physical examination and calculate her gestational age using the Nagel's rule. And then you get an ultrasound at 10 weeks gestation to get a crown rump measurement. So those are pretty good ways in order to know, more about her. Attain vital signs. Yeah, you get a baseline blood pressure, and so baseline weight, so that we know if she's gaining too much weight during the pregnancy too fast, or she is starting out already hypertensive. And so we need to get that, okay? All right. So here's our blood work again. So HIV, CBC, rubella titer, hepatitis B, syphilis, a VDRL. Gotta know it's important to know between the syphilis and the VDRL. We want to know is any viral diseases, and then of course RH and blood type with anybody screen. We're gonna look at the do a pap smear and make sure there's no what we call cervical dysplasia down there in the vagina. So we're going to do the pap smear. And vaginal cultures like gonorrhea and chlamydia. And then if she has a history of sickle cell in the family, we'll do a hemoglobin electrophoresis and then a urinalysis, checking for nitrites and WBCs, so leukocytes, blood. We look for those things because we want to make sure that she doesn't start out with a UTI. All right. So again, we're going to do routine assessments at each prenatal visit. Now, this is what we do at the normal routine prenatal visits, okay? So again, you're going to assess her risk factors and kind of assess for new ones in case something popped up. Vital signs and weight to evaluate weight gain and changes in blood pressure. Urinalysis, protein, we're going to check for protein, glucose, ketones, albumin. Okay, we look for protein because around 20 weeks gestation, she might develop hypertension related to preeclampsia, and then she spills some protein. So we want to make sure that she's not doing that. Glucose, she could be, maybe she's going into gestational diabetes and would be spilling glucose in the urine. So we're going to look for that. And then ketones, make sure she's eating properly, and albumin levels. Blood work. We're going to always monitor for anemia because during pregnancy that can occur. And it can occur in a woman, maybe she has pseudoanemia, as we talked about the other day. So we're always looking to make sure, especially if she keeps complaining of being fatigued and maybe wanting to chew on ice. That's also another sign of anemia. Fundal height. We got to measure the fundal height in order to determine if the fetus is growing properly. Okay, so we take the little tape measure and put it down the symphysis pubis and come straight up the linea negra and come up to the fundus of the uterus. Okay, and also you can determine if she has enough amniotic fluid volume. She's got to have enough fluid volume to keep that baby growing and not to have any growth restrictions. Lever pose maneuvers. Okay, this is where we put the hands on the belly and we can assess just know if it was presenting. If the head is presenting, that's called cephalic, which is the head, and this buttocks is here, up on the top of the front of the uterus. Now, we can determine just by our hands. All we can determine though is either presentation or position of the baby. Either his head first, or could be the other way. It could be that it's breech, so then his buttocks would be down lower, and when you get in, how you feel it is soft. Okay, it's soft, and then the head would be hard. So that's how we feel. So we can feel what position of presentation baby's in. And then you got the fetal heart rate, which is 110 to 160. And then you got nutrition intake, especially in the third trimester, because this is really a rapid time of fetal growth. And then you have any discomforts or problems since your last visit. Has anything cropped up? And if she says, well, I notice my feet are swelling more, then you tell them, well, at the end of your day, make sure that you put your feet up, okay? And let somebody wait on you. All right, lift the feet so that you get the swelling to come down. Okay. And if you're sitting at the desk, like I have a desk job, then you want to make sure that you get up every so often and walk around, just as you would do if you were traveling in an airplane. You get up and walk the airplane, and make sure you drink your fluids and go into the bathroom. Okay. Now, these are some terms that are related to pregnancy that you saw in your book. And gravida means pregnancy, okay? And then no gravida would mean she's never pregnant, and prima gravida, first time pregnant. Multigravida, she's been pregnant for at least second time. And then para is the number of pregnancies that have reached 20 weeks or greater. Okay. A way that we can determine estimated date of delivery would be using Nagel's rule. And so Nagel's rule, all you have to do is take the first day. What day? First day of the last menstrual period, okay? And you count back 3 months, okay? So say it was January, then you would count back what? December, November, and October. You count back 3 months. And then to that date that she gave you, that was the first day of her last menstrual period, say it was the 7th, January the 7th, right? You would add 7 days to that 7. So her due date would be like October 14th, okay? And then of course, if you need to, if it's appropriate to go to next year. But that's the easiest way. Here's also your history, OB history, So here's your 2-digit. Gravida and para. So again, write these down to know them because you will see them again. Gravida refers to the number of times a woman is pregnant, regardless of duration or outcome, okay? She gets credit for the number of times she's been pregnant. Okay, then para means it refers to the number of pregnancies that have reached 20 weeks or greater. Remember, 20 weeks is your cutoff for the viability. So before 20 weeks is non-viable, but at 20 weeks, the fetus can be viable. So we count that in. So 20 weeks or greater. And then you have the 5-digit. Now, this one we use in the very beginning, the first prenatal visit, because I want to know how many babies were term. I want to know how many babies were premature, and did she have any abortions or miscarriages? And we go into those because you can have recurrent ABs. Maybe it's due to a lack of progesterone, because you need progesterone to maintain a pregnancy. And if a woman is low on progesterone, then she might abort the baby. Okay, so that's what we want to know. And then of course we want to know how many she has living children at home. Okay. Again, this kind of reverts back to Nettles' rule, but you can practice with that. All right. Let's skip over that. Now, the trimesters, you have pregnancies divided into 3 13-week parts, okay? So it's important to know what occurs during each trimester to both the woman and the fetus. And in your book, you have a really nice chart on that, and it shows you exactly what to expect, okay? So the first trimester is like from week 1 to the end of week 12, okay? Then the second trimester is week 13 to the end of week 26 is 13. And then you have the third trimester from week 27 to the end of pregnancy. And usually we call 40 weeks as term, but then she can go past her due date and she gets into 41, 42 weeks. It turns into what another term called post-term. Post-term. Okay. Now, these are some signs of pregnancy. And so these are called presumptive, which is felt by the woman. And then you got probable, which is picked up by the examiner. And you got positive, which you have an ultrasound or or you hear the fetal heartbeat, and that's pretty positive that you have a baby. Okay, so a good test question could be give you some signs, you know, and then you have to pick out is it presumptive, probable, positive. Okay, I mean, I don't know that for sure, but that's pretty good. All right. So amenorrhea, which is called, lack of menses or cessation of menses. She'll have a period. But it could be caused by other things other than pregnancy. So you got to keep that in mind. The nausea and vomiting. Okay, we know that increase like estrogen, HCGs, those levels, progesterone early in pregnancy can cause a lot of GI upset and cause nausea and vomiting. A lot of women have that. And when you have that, the easiest thing to take care of that is to have her have some maybe some plain crackers. You know, we like non-salted saltines, okay, where she can have them and chew on them even before she gets her head off the bed, okay? Because some people, as soon as their body comes up, they start to feel this up and down business in their esophagus. And so have her chew on some crackers even before she brings her head up. Okay. Now that's another good test question. Okay, deepening pigmentation, all right, due to the hormone surges. Remember that. So chloasma is another one, which is the mask of pregnancy. And they look like they actually have a mask on. Then you have the linea negativa, which is that dark line coming up the middle of her abdomen. All right. That's another pigmentation of the skin due to hormonal changes. And then urinary frequency and urgency of urination are common in the early parts of pregnancy. Again, you have hormonal changes that actually relax the tone of the bladder and also their uterus. Okay. And then you have fatigue and drowsiness are early signs of pregnancy, and quickening. Now, quickening is another term that I want you to write down that you'll probably see this one again because everybody likes to put these terms on tests. Fetal movement felt by the mother, and it's felt by her. And it's usually around 16 to 20 weeks of gestation as a faint fluttering in the lower abdomen. Now, the next sign of pregnancy is called probable. Okay, so it's called probable because these are signs that the examiner themselves see. Okay, so the examiner is looking up, your vagina, and they can see what's happening to the cervix. And so when the cervix becomes like purplish and bluish discoloration of the cervix, because of all that blood congestion in the lower part of the cervix there, and it makes it look bluish, purplish. That's a pretty good sign because of the vascular congestion. Now, another one you can see is a softening of the cervix and the vagina, and that's increased by what? Vascular congestion. And then you have Hager's, which is a sign, softening of the lower segment of the uterus. Getting ready, everything's ready. Everything is there, okay? Everything is prepared. And then McDonald's sign, you have flexing of the uterus actually against the cervix. So these are all very much so, okay? These are probable. Now, you have some positive signs of pregnancy. And if you can put a Doppler on her belly, you can hear the boom, 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 okay? That's pretty significant that you got a baby in there. My biggest one is I love this ultrasound. You actually see the visualization of the fetus. And again, another one, reason why I like the ultrasound is I can see the little heart. The little heart is beating, okay? And when you have a fetus and you have a heart beating in there, that's a good sign. And that's a good sign. She's positive, of course, but it's a good sign it's a good pregnancy because if she didn't have a heart beating in there, And then you would have a molar pregnancy. And so that would be very significant because that wouldn't be a baby. It wouldn't be viable. It'd be just a cluster of cells. And we'll get to talk about that, I think, next week in complications. So anyway, again, positive sign is the ultrasound. Now, that's a pretty good test question, too. So make sure that you really understand these 3 signs of pregnancy. The presumptive felt by the woman. Remember the you in presumptive, okay? You, the woman, all right. And then you have probable. Those are signs that are picked up by the examiner. And then you have positives, which are signs that the fetus is there. Okay, so I just summarized it here for you. And you probably want to, look at them. And but again, like the presumptive signs, those are things that are frequently associated with pregnancy, but the little word but, it changes everything. But there also can be attributed to many of the phenomena that can help happen as well. So that's why they're not positive. Okay. And you have to get your mind thinking that way, because I know a lot of people think, well, you don't have a period, you're pregnant. And that's not the case. There's problems in the woman's body that can cause her not to have a period. All right. And then probable is the examiner. Okay, that means it's a really good chance of this happening, but let me go further and let me determine better. And so we go with the positive sign, which is the actual presence of the pregnancy. And you can see the fetus and the heartbeat. Okay, so an antenatal client is informing the nurse of her prenatal signs and symptoms. Okay, so she comes into the clinic and she's telling you, the nurse, oh my goodness, all these signs. And you've got to determine which of the following finding with the nurse determined is a probable sign of pregnancy. So remember, probable was by the examiner. Okay, so then you would say, go down here, and that's not the examiner, amenorrhea, so that's out. Quickening is felt by the mom. That's the first feeling she has. Breast tenderness is felt by the mom. So these breast tenderness, quickening, and amenorrhea all fall under what? The presumptive sign. So the one that will go under the probable sign would be Chet. So that's how that would work. Okay. Now, this is the measurement I talked about, fundal measurement, and it's really good. It's a simple measurement that can be done. A lot of times in the offices, they have the nurses do it. But here's a practitioner, looking at his patient and determine, okay, how is the baby growing? Okay. And so he puts part of the tape here, the beginning of the tape, down by the symphysis pubis. Okay, right here, the little notch. You can feel that little notch. And then he takes the tape straight up her abdomen. And this is called the linea nigra. And can straight up that linea nigra to the top of her uterus, which is called the fundus. And this is the fundus, okay? So the top of the uterus. And then he can see his measurement. So if she's 38 centimeters, then she would be 38 weeks gestation, okay? If she was 26 centimeters, measuring 26, then she would be 26 weeks, okay? Now that's how it equals. The number of centimeters equals the number of weeks gestation. This is a nice way to determine if she's got enough amniotic fluid, if the baby is growing, all right? Because then if that doesn't match, then what you can do is you can follow up by an ultrasound. And at the ultrasound, you can see the pockets of fluid, so you can measure how much fluid is in each pocket. And then you can look at the fetus and look at his femur and his heart and the body and the head, make sure that the baby's growing. Okay. All right, so when we talk about adaptations to pregnancy, we're talking about now how the woman's body adapts, okay? And so we go through a couple her systems. One is respiratory. And in respiratory, she actually has oxygen consumption that increases by 15%. Now, that's quite a bit, all right? So what happens is their diaphragm actually rises like for about 4 centimeters, so equal to 1.6 inches. And then when that happens, then it causes the ribs to actually flare out. And because it has to allow room, okay? Because no matter what, this baby's growing. And so she becomes a little dyspnea, which is difficult breathing, and then it occurs until the fetus descends, it goes down into the pelvis. And it will go down. Around 36 weeks, it goes down. And this here shows you can see here on this drawing, you can see here, this will be at 40 weeks. And now she has what we call a little lightening. Okay, lightening, that's another important term that I think will be good for you to write down. And you have lightening. And lightening means dropping. The baby drops down into pelvis, okay? And so when that happens, then her uterus now drops down, okay? And so that allows her some extra area to breathe, all right? Which is really important. So a lot of ladies at that time say, oh, you know, Nurse Irene, I can breathe better. And I go, that's because the baby has now dropped. And that's called lightening. All right. So again, her breathing will be a little bit easier after the baby drops, which is very, very nice. And then sometimes with the respiratory, you know, estrogen is the culprit. And if those increases of estrogen cause edema and a little swelling of the nose. And sometimes they can get nosebleeds. It's very common for a pregnant woman to have nosebleeds and nasal stuffiness and voice changes even, okay? So, you know, again, respiratory is affected. Now, another organ that's affected is the heart, okay? There's a lot of blood pumping. Don't forget, mom has her own blood pumping, right? Now she has a growing fetus, and the fetus needs blood because blood carries oxygen, and they need oxygen to what? To survive, okay? And for his heart to survive. So blood volume increases by 45 to 50%. Okay, that's a lot of cardiac output. That's a lot of strain on her heart. So hopefully she's in, remember that first prenatal visit we talked about conditions and a medical history? Well, this is where it comes into play. Because if she had any kind of heart involvement early in life, or she has to be watched very, very closely. Should be a high risk patient if she had cardiac disease, because there's such a amount of pressure put on the heart. So don't forget, you have exchange of nutrients, okay, exchange of oxygen and waste products within the placenta. Remember, the placenta is the baby's, the placenta is the temporary endocrine organ. And so what happens is that there's a lot of nutrients that have to be exchanged between oxygen between the mom and the baby. So again, cardiac blood volume increases by 45%. All right. So now I'm going to go on and let's see. And again, too, it increases by 45% because also there's a lot of blood loss. There's blood loss at birth. And so in order to accommodate that blood loss at birth, guess what? It's because of that increase of blood that she has circulating. Now, write this down because it really is significant. Pulse rate does increase by 10 to 15 beats per minute. Okay, so to wrap up here, the cardiovascular system gets affected by the pregnancy. Blood volume increases by 45 to 50%. And you have that in order to mom to keep going and for the fetus, the growing fetus, to have the nutrients, oxygen, and everything it needs. Okay. All righty, let's go on here. And we're going to talk about a syndrome called supine hypotension syndrome. It's also called compression vena cava syndrome. What happens is that a woman lies flat on her back, all right? And what happens is all that heaviness of the uterus, it compresses the inferior vena cava, okay? And when that happens, it presses on the vena cava itself and it will compress it, push it down. All right, so blood return is reduced to her heart. Remember, we told you she needs the cardiovascular system, she needs blood. So when you compress the inferior vena cava, it decreases the amount of blood. All right, which can lead to both mom feeling fainty, lightheaded, dizzy, and agitated. So what are you going to, and then the worst part about it, it can lead to fetal hypoxia. Never good, because then his heart rate will go down. So then what are you going to do for a patient that is complaining of this kind of syndrome? Anybody know? How about we turn her to her side? Right. Just like my little picture here. This looks pretty good, pretty comfortable with a beautiful pregnancy pillow. Just turn her onto her side. Left side is preferable because left side gives you more placenta perfusion, blood perfusion. So turning to left side is good. All right. Got to keep the blood flowing to both mom and baby. So I love this schematic drawing, comes right out of your book. And so here she's laying what? In a supine position. No, no, no. But anyway, here we go. And then here is the inferior vena cava. Okay, so this is a lot, you know, you got about 5,000 mLs of fluid, you got the baby, you got a lot of weight in this uterus that's pressing against her inferior vena cava. All right, and here it shows you, I love this picture because it shows you the uterus during a contraction, okay? Contraction, it gets really hard, and so she's a lot of pressure, okay? And his heartbeat will go down too. We don't ever labor someone on their back, okay? And then here's, it shows you the uterus between contractions. You can see the difference, all right? So again, what are you gonna do to help her? Turn her on her side, okay? Like I said, the left side is the one that we use the most, but it doesn't matter. I flip them to either side, no matter what I do, I get her off her back. So again, the little brain teaser, the nurse educating a pregnant woman in her last trimester will encourage her to sleep on her side because it will what? What would you say? What would you say would be the answer?
Relieve bladder pressure.
No, it will prevent hypotension.
Hypertension.
Okay, so let's go back here. And so when you have like when you have a patient laying on her back,
Mm-hmm.
okay, the uterus and the baby will press down against her what? Against her inferior vena cava. She'll have decreased blood, all right?
Oh yeah.
Therefore, she will feel fainty, lightheaded, dizzy, actually, and her blood pressure will go down. When her blood pressure goes down, because you have reduced blood return to her heart, okay, it will also cause the fetal to have less oxygen also. So we don't want that, okay? So what we're doing is we turn her to her side to relieve the pressure off that inferior vena cava, therefore increases the blood going to her heart, therefore prevents hypotension, all right?
Okay.
So you how that question could be asked. And that's a pretty good question, hint, hint. All righty. Okay. All right. So you got that now?
Yeah.
Okay, good. Okay, let's talk about weight gain in pregnancy because, you know, a lot of women come in and they're very conscious about their weight. And so if she's of normal height, okay, normal height, and that's how the question will be asked, normal height, then she can have a weight gain of 25 to 35 pounds, okay? An overweight woman, she already has on extra weight, so we have to limit it, what she can gain. So we limit it a little bit, 11 to 25 pounds, okay? And then if women come in already and they're quite obese, they have a limitation of 11 to 15 pounds. What you normally see on a test would be a woman of normal height for what would be her normal weight gain during pregnancy. That's usually 25 to 35 pounds. Now she can increase her caloric intake by 300 calories. Okay, not too bad, right? And so, but those 300 calories, you have to make sure that they consist of what? Protein, calcium, have a good supply for iron, and then of course she takes her folic acid. So then make sure she's got chicken instead of French fries. Okay. And she's having maybe some milk, yogurt for the calcium. She's getting her calcium. Now she could be lactose intolerant, as we know, then you can have a lactose free, or soy. And then you got iron. Make sure she's got her green leafy vegetables. What legumes are pretty good for that. And so she's getting her iron. Just make sure, I use that like what's that website? Government, oh, myplate.com.
My plate.
Yeah, that's a really good thing to use when you're teaching someone to visually see what they should be eating. And also, I tell my patients, you should have a pretty plate. And they look at me like, what? Yes, it should be colorful. When you have a colorful plate, you have a good mixture of protein, iron, and you have it all together and limited carbohydrates. Like have a sweet potato, have a piece of chicken, have some legumes, okay? How about some green beans, things like orange for carrots, things like that. Make it pretty looking. And then they actually get the picture that way. Now, you may have some special nutrient considerations, and the big one is pica, P-I-C-A. Pica is a craving for a non-food item, such as maybe some
That'd be like
starch.
cornstarch.
Yeah. And what else?
Some people eat toilet paper when they're pregnant too.
Yeah. I mean, it could be anything. So, I had a friend that ate soil. So, what we do is we don't judge what they're eating. We may say in the back of our head, but we don't say that. Okay. We say, well, I want to know, Mrs. Jones, how much of that toilet paper are you eating? How much of chalk are you eating? How much of the soil are you eating? And I just write down. So it's usually a craving. You can get a little bit and get satisfied because the brain is craving, sends those signals. And so if you pay attention to it and you have a little bit, then it goes away. See, and there's no more craving. All right. You ever like a pregnant lady wakes her husband up in the middle of the night? Honey. And he goes, yeah, what? Oh, I just had to have a taco. I've had women that wake up their husbands and say, I have to have a taco. And the taco is not from Taco Bell, it's from Jack in the Box. So he has to go all the way on the other side of the county to get her to have a taco. Now he comes home, and guess what? She's sleeping. It's because she got that craving satisfied, and he's standing there with a bag of tacos. So those are things that happen during pregnancy, and they're called cravings, and they're cravings for non-foods. Now that was a food substance that she wanted, but she wanted a certain food. These pica are like soil, toilet paper. Kind of interesting phenomenon, really is. But you probably see that again. Okay. Now, we also have other considerations such as what? Pregnant adolescent. Okay. Now, what kind of foods do you think the pregnant adolescent like to eat?
Chips, candy.
Yeah, maybe some sugary cereal. Okay. Maybe some French fries. I know a lot of pregnant, they sit there with a big old bowl of French fries. And, you have to work with the pregnant adolescent. Sometimes if us talking to them doesn't get through, then we refer into a dietitian. Okay. You do what you can. Now, some pregnant adolescents don't want to eat at all. Okay. They really limited their intake because they don't want their bellies to get big and people know that they're pregnant. Because sometimes what happens, they hide their pregnancy. Very well known to do so. I've had patients where they wore tight girdles, okay, to hold in their stomachs. And that's the worst thing because the fetus is growing. And if it's restricted in there to grow, then what happens? You have a baby that's born with maybe small limbs or abnormal limbs or maybe some hip dysplasia the newborn gets. So you have to be very careful. I usually tell them off with the girdle. Okay. That can be for later, but not now. And that really does happen. Then you have people who have to watch their sodium intake, and the vegetarians, they have to get their proteins. And I talked about lactose intolerance and cultural preferences. Everybody sometimes has a cultural preference. You have to be careful with that to make sure that what they're eating doesn't contain a lot of hidden sodium. Okay. And then we have gestational diabetes, where after the sugar intake, because you can acquire diabetes in pregnancy. That's why it's called gestational. We usually test for that around 20, say between 26, 20 to 28 weeks to see what's going on. And some people can just be controlled with a diet. And sometimes they go to like a couple classes to learn what to eat and how to look at food. And then the good thing about gestational diabetes that after she delivers around 6 weeks, her sugars will revert back to normal. And but once you have gestational diabetes, she has to be on alert. That's one of the risk factors. What I talked about earlier this morning in the beginning of the lecture, is that you have to be careful. Okay. Yeah, I want to know in the beginning of her pregnancy, of this pregnancy, do you have any history of gestational diabetes? Because the chances are, if we don't watch her diet, she can get it again. All right. And gestational diabetic patients have big babies. They have macrosomic babies. And that's a good term to write down, macrosomic babies. Those are large babies. They're like, they weigh about anywhere from 8.8 pounds up to what? Up to
Like
9
12.
pounds and greater to 12 pounds. Sometimes you ever see those big babies, they're 16 pounds.
Mm-hmm.
Yeah.
Yeah, my sister had a 12-pound baby. My nephew
Oh,
was 12 pounds.
okay. Now, was she a gestational diabetic that they know of?
Yeah, she was.
Yeah, yeah. And those babies, bless her heart, hopefully she delivered that baby C-section.
Nope.
Nope. Oh wow, your sister. Woo, we got to give sister kudos there.
Yeah.
Yeah,
She had like 14 stitches.
yeah, yeah. So she had a C-section. We call that probably she had a fourth degree, probably we call that a C-section from below. Okay. And what they do is they have to cut in order to allow the baby plenty of room, the skin stretch out so that babies can come through, because it's got a big head. And then also about a macrosomic baby, they have wide shoulders.
Mm-hmm.
They look like little football players when they're born, and so they have these wide shoulders, and they're just quite big at birth. So congratulations to your sister. Okay, now when you're breastfeeding, and I always say breast is the best. Okay. I tell my patients, if you breastfeed, you get 500 extra calories. I think that's a great amount, 500 extra calories. Woo, okay. And I tell my young patients, breastfeeding makes the process of involution go faster. That means involution is how the uterus descends back down into the pelvis. So usually involution is about 1 to 2 centimeters per day. When you breastfeed it, it goes a little bit faster, and then you can get into your skinny jeans. Once I say skinny jeans, they go, okay, how long you want me to breastfeed for? And I say, oh, I love your breastfeed for at least 6 months. And so I get to breastfeed. Because breastfeeding is the best. And we'll go over that a lot in newborn. But it's such a great bonding process between mom and baby, and also baby gets the immunity factors, the antibodies from the breast milk. So is breast the best? Yeah. Okay. So anyway, I just to get back, they get 500 extra calories. And then of course, again, protein she has to be good diet, calcium and iron. Same as during pregnancy. So I tell my patients, you know what? Make it simple on yourself. Take your multivitamin. Keep taking your multivitamin that we gave you for pregnancy. Take it during breastfeeding. And then, limit your caffeine and your alcohol, because anything that mom takes in will go right to the breast. Okay, so I tell them to limit. Otherwise, if you have caffeine, you're going to have a baby who's going to be bright-eyed and bushy-tailed. He's going to have eyes like this, wide awake, and you're going to be tired, and you won't
The
get
baby gonna be up.
Yeah, he'll be up. Oh yeah, oh absolutely. And of course, drugs. If mom has to take something, she needs to let her physician or her midwife know so that they can guide her, because it should only be on the advice of the healthcare provider. Again,
Mhm.
drugs will cross the breast barrier and go right into the milk. All righty. Now let's talk about exercise. Simple. Exercise should be for only maintenance of fitness. That's it. You're not looking to, have weight loss. You're not, improving, like, I'm going to work out and get more muscles. No, it's just basically maintaining. It's not going to be honest with you. My patients that were up and during pregnancy and they were, maybe they were walking around and they walked every day a little bit. They did wonderful in labor. And then those pelvic muscles were strong. So when it came to the second stage of labor and pushing, all right, she was pushing, she could push that baby right out. And so that's what I tell my ladies. I had a woman come in, and this is an honest truth. She comes in and she says to me, and so we're talking about the pregnancy, and she's saying, "Well, I'm going to run in a marathon." I said, "Oh, really?" I said, "Have you run marathons before?" And she said, "No." I said, "No, you're not going to run in a marathon because you don't start that. You train a long time for a marathon."
Mhm.
and you can wait to after you deliver to do something like that, and then you start your training. So I know all of a sudden these ladies had never exercised before, they become pregnant, and all of a sudden they want to have these big exercise things happening. You can't do that. Just want maintain pregnancy, and I share that with you so you can kind of remember that. All right, because when you exercise and you're pregnant, your temperature can go up, and that impacts fetal circulation and cardiac functioning. It also can make her blood pressure go down, so hypotension, and that's how some patients actually faint when they're outside, and that because you have reduced blood flow to her heart, and then of course it reduces the blood flow to the fetus. Not a good combination. And then again, cardiac output would be decreased because again, you're overdoing it. I always tell my patients, if you are with somebody, which you should be, and you're walking and you look over and you're not able to talk to that person, like a normal person, you're not able to talk to them, I want you to stop, sit on the park bench, relax a little bit, get some good breaths in, and see if you can continue to talk. Because when you can't talk and you're exercising, that means you don't have enough what? You don't have enough
Oxygen.
reserve. Yeah, you can't. So can't do it. So I tell them that. And I say, you can go back when you get after you deliver and get back into a normal routine of your exercise. Now, travel. Air travel, and you probably see this again, air travel is safe for women up to 36 weeks gestation, up to 36 weeks. So you want to avoid sitting for an extended period of time in the plane. I tell them to get up and walk the aisles, back and forth. Avoid locations that could risk their exposure to a bad disease, infectious disease. You don't want to go to a third world country because it could have exposure. Don't put yourself in that kind of situation when you're pregnant, because when you get sick, your baby will get sick, and that's not good. All right. And then I always give them a copy of their obstetrical record, and they'll say, "Oh, don't worry, I'm probably my hospital will talk to that other hospital, by computer." I have found out not all hospitals have that ability, so it's just as well. We can just print it up. Here's what we've done for you, okay? And that will have her blood type on it and all the important information that they need, so they don't have to redo. When you don't take your obstetrical record with you, they have to redo all that information, and that's a lot of money for that blood work. And a lot of insurance companies will not cover that because you had it done already. See? So don't do that to yourself. And then if you're going like from New York to Orlando, Florida, you want to make sure that wherever you're staying, that there's a hospital. Know about the facilities, because it does happen here in Orlando a lot. I will tell you, we get a lot of tourists, right? And so they
Mhm.
come from all over the United States, and they usually come in the summertime, okay? And they usually want to come to Disney. And so they're quite pregnant. Now I go to Disney, I see all these pregnant ladies. I'm going, oh goodness, okay. I hope she's taking in her water, because what happens is they get dehydrated. And when the body gets dehydrated, guess who else is decreased to the fetus? So
The
mom
baby.
gets sick, mom gets fainty and lightheaded, and baby his heart rate will go down. And we usually see them at the hospital. We usually get them in triage and get an IV in them real quick and get them rehydrated. And because when you get dehydrated, the uterus starts to contract. And
Mhm.
when the uterus starts to contract, her cervix will open up. So we hydrate them real quick, get the uterus to quiet down, and it stops contracting. It's remarkable. It stops contracting, and so therefore her cervix doesn't open up, because then she would have a preterm baby, and we don't want preterm babies. We want to prevent that from happening. So that can happen. So we tell them, just be careful. Okay. Now I have this here because this is in your chapter 4. This is about Reva Rubin, wonderful lady. She identified these. She has this called my maternal identity. And what happens is she identifies 4 maternal tasks the woman accomplishes during pregnancy. Okay. So a woman sees herself and sees like a self passage or a safe passage for herself and her fetus. Okay. She secures acceptance of herself, okay, as a mother and for her fetus. Remember, there is a deep connection between mom and her growing fetus. So she has to kind of visualize this safe passage. Not only that she'll make through labor and birth, but for that her baby will do so too. And then she learns to give her herself and to receive the care and concern of others. Not easy when you've been on your own, especially I see this in the advanced maternal age patient, like 35 years and above. They've done a lot for themselves, right? And so they have to visualize now, they have to let that go. Okay. And they have to now think of the care and concern for her baby. All right. Not so easy. And then committing herself to the child as she progresses through the pregnancy. They go from the very beginning of pregnancy, where sometimes I said before earlier today, I said there's some ambivalence, the very beginning of pregnancy. Oh my
Mhm.
gosh, I'm pregnant. I wasn't planning on this. Oh my goodness. And then they have to go through the adaptation. They have to change. That's what adaptation is, changing. And they have to realize things are going to happen. And we're going to go through the pregnancy, and I'm going to work with my baby and work with, say, my practitioner, and get through the pregnancy safely. I love Reuben. Sorry, Reuben. She is a fine lady, and she just passed away, I think, in 1995, which is, I guess, not too far back, but somewhat. All right. Now, if you have a chance, look her up. She's a really interesting lady. And then developmental stages of fatherhood. Yes, I don't leave the daddies out. No, they're important. Now, some daddies are right in there with them. Some daddies are it takes a little time for them to come around. So they go through the stages of announcement when the pregnancy is confirmed. Oh, okay, honey, we are pregnant. All right. What does that mean? All right. And then they learn to go through another stage of acceptance. Okay. All right. When that happens, let me tell you, the results are phenomenal. It strengthens that family unit. Okay, when the father of the baby accepts the pregnancy. Okay, and then they go through a period of adjustment, and your book goes into these a little more detail, and they have focus. And what they do when they focus now, they focus on, okay, how can I participate in this labor? Okay, we'll go through the prenatal classes with her. Well, the birth process, what can I do? Okay, we'll be there, wipe her brow, rub her back, walk her down the hallway. And so we go through all these little things that daddies can do. because now they're focused. A period that takes a little longer is the period of adjustment, because they have to adjust their lifestyle. Now they've been single, and they have been, doing their thing, and then they bought their Corvette, and they have maybe their boat and all these kind of really nice toys. Sometimes they have to take that Corvette and get a minivan. All right. So I got a little cartoon here I thought everybody would like, and this is true. Okay. So the nurses are here talking, and they said, hey, it's a good thing fathers are allowed in delivery rooms. And the other nurse goes, yeah. She goes, yeah, I don't think that I could take that kind of abuse. Okay. So here's a little smile, and just wanted to show you. Okay. It does happen. Okay. All right. We know that in daddies have a great impact on the labor process, on the pregnancy and the birth. Okay. And daddies that don't maybe seem uninterested, it could be their culture. So don't make any kind of assumptions or anything about that. All right. Now my other group that I do have a tendency to have a big impact on is the adolescent. The adolescent is a time of change and adjustment to begin with. And then this poor pregnant adolescent, she faces multiple hurdles as she transitions through both development and during the pregnancy. Okay. She's growing herself, and so she may be in school and she may not have a support system that she needs. Adolescents need support. They need help with nutrition. They need help, sometimes help lodging. Sometimes their parents don't accept their daughter's pregnant. I had a 12-year-old, 13-year-old, I labored them. And it is very hard on not only on her, but on the family. So you always want, when you have someone like that in labor room, you always want to focus on her developmental level and her priorities typical of her age. Okay. So if I was to ask you, what would be the first priority in working with the pregnant adolescent? And
I
that
would
would
say
be
mental health.
her mental health. Yes. So you want to assess her attitude during pregnancy. Absolutely. That's where you start. Now you may want to do all other things, but that's what you start. And when you do that, you know where she's at in her development and her emotional development, and then you can go from there. Okay. And that comes, and when you do that, you develop trust with your patient. Now, my other group is the older couple. Now you probably say, well, what's wrong with them? Well, they have every group has unique concerns because everybody's unique. But they have problems with, maybe they don't have any problems financially, and they've gone through college, gone through school, and they're establishing their jobs. But that's the problem too, because now they gotta have a baby. Babies there's a lot of care. You have to take off from your job. These are different things, but it's a problem. It's a problem when you may be director of the hospital and now you're pregnant, and so you're torn between your job and your infant. So again, they have unique concerns and needs. And my single mom, I'm very much associated with, I have a great heart for them, is that they could be either an adolescent or a mature woman who's doesn't have anybody in their life. The father of the baby is no longer with them. They have a unique emotional needs because they have to worry. These single women maybe they have to worry about finances. You see what I mean? So maybe they're in the hospital a lot because maybe they had a condition, hyperemesis gravidarum, where you go in the hospital a lot because you continuously vomit. And back in the day, back in the 1950s, women, if they got pregnant, they lost a job. Okay. And because they were maybe in the bathroom throwing up. And so they have financial concerns, lifestyle changes. friends. Okay, they're by themselves. All right. So a young girl can't go out with her friends anymore because she has a baby. Who's going to take care of the baby? So those are things I'm talking about when you have these groups, either adolescent, single mom, an older couple, no matter what. Okay, everybody has unique problems. Okay, coming to an end pretty soon. Just going to go over immunizations and pregnancy. What I want you to take out of this slide is live viruses, live, are contraindicated during pregnancy. So like the rubella, okay? Like I said in the beginning of this review, rubella, you have to be careful, okay? So rubella, when they come in for the prenatal first prenatal care, I'm gonna find out if she's immune. I can do a rubella titer. Okay. If she's not immune, okay, and she's pregnant, I do not, NOT, give the rubella vaccine to her. Nope. I wait after she delivers. She's on your unit postpartum. You can give her the rubella vaccine. She can breastfeed, all right? But you do not give her that rubella vaccine during pregnancy because rubella has significant causes significant problems to the fetus. So we don't do it. But we want her to have the vaccine so that if she gets pregnant again, we have no worry. So after delivery, she has even then, she has to wait another month before she gets pregnant. You probably say, well, she just had a baby. I've had patients that had babies and I saw them back a month and a half after they had the baby, they were already pregnant again. So that's why I always say, you never assume anything. So I give her that rubella vaccine after delivery. She has to wait a month and then she can go on. But she can breastfeed. That's wonderful that she can breastfeed. So that's how it goes. So don't ever give her a live virus to a pregnant woman.
So
All right.
rebellion won't affect like going through the barrier of like if she breastfeeds.
Yeah, breastfeeding is okay. I'm very happy about that, aren't you? That she can, and she can get the rubella, but she cannot while pregnant because the rubella vaccine is a live virus, and therefore it can affect the growing fetus.
Okay.
Yeah. So you probably see that again. So that'd be a good thing. You do not give it during pregnancy. You wait.
Okay.
Now, say she wasn't pregnant. Okay. If she's not pregnant, she comes into you like for preconception counseling, which I love when they do. Then you go over, all these things with them. And she says, I'm not sure about rubella. I had a meet MMR when I was like really young. I think I did. So I said, no problem. We can do a titer. And we find out that she's not immune. I said, no problem. We can give you the rubella vaccine, but you wait a month before you plan to get pregnant. You have to have that waiting time in there so that nothing occurs because a live virus will live in your body for a while. So you have to wait a month, your body takes in what it needs, and then it secretes everything else. So you don't want that thing living inside of you and be pregnant. So I think that's it. Let's see. I say, guys, that's all, folks. All righty. So be sure there is on our resource page under announcements, there's a resource page. Be sure to click on that and see the weeks. Week 1, week 2, week 3. So in week 2, there's a whole bunch of questions there. See if you can answer them. Okay.
Okay.
That's a good indication. Week 1, I read all these. Week 1 is great. Okay. Because they're in our lectures. That's where we kind of base some of our lectures on. And so you want to make sure that you can answer those questions. Now, there is a Kahoot. There's a Kahoot on week 1, and there's a Kahoot on week 2, which is really, really good. Okay. So go on the Kahoot, and there's one for chapter 4. All right. So go on the Kahoot and see how you answer. You can do it as many times as you want. All right. It's unlimited. And it'll get you ready for your exam. Okay. And of course, if you haven't had your quiz yet.
Yes.
Oh, okay. Because it would help you on quiz 2. No, quiz 1. All right. So anyway, all the resources are there. And just make sure that you read your chapters, you made your notes. And then I always say, look at those key terms in the beginning. Keep in mind when you're reading, oh, that's where it is. Quickening, lightning, aha. And then you say, oh, she did this morning. Those are always good. And then of course, anything we put out there is good for you. Okay.